Welcoming you again. Welcome to tonight's event with Dr. J. Bhattacharya. My name is Martin Hunke, and I'm one of the co-chairs of the Braver Angels Tucson Alliance that hosts tonight's event. A month ago, we held a similar event with Dr. Francis Collins, a former co-chair of our alliance, has close ties to Dr. Collins, and that connection led to last month's event. Though technically a Tucson Alliance event, we promoted it in the Braver Angels weekly newsletter, which resulted in people joining from all over the country. And after last month's event, some Braver Angels members reached out to us and expressed concern that we gave a platform to someone closely linked to the government's response to COVID. And they urged us to do a similar event featuring an expert critical of that response. Which brings us to tonight's event. Before we introduce tonight's featured guest, let me introduce Wilk Wilkinson, host of the Derate the Hate podcast. Many of you know Wilk from this year's Braver Angels convention, where he and Dr. Collins had a plenary session titled "A Deplorable and an Elitist Walk into a Bar." Wilk invited Dr. Bhattacharya to speak to us tonight, and we are very grateful for him for making this event possible. We will hold tonight's event in the same fashion as we did the event last month. All participants have been muted. This ensures the Q&A session later is not monopolized, and we get to hear from as many voices as possible tonight, as our limited time allows. Dr. Bhattacharya will first speak to us, and then we open up the Q&A with questions many of you submitted during the registration. We have already received plenty of questions, but we also want to offer you to submit further questions during the event using a Google form. You can find the link in the chat for this form. Please bear in mind that we cannot consider these questions for tonight's Q&A though. On behalf of Braver Angels and the Tucson Alliance, I welcome you and thank you for joining us tonight. And with that, I invite Wilk to take over and get tonight's event started. Wilk, please unmute and go ahead.
Good evening, Martin, and all the other Braver Angels here, and good evening to our special guest, my good friend Dr. J. Bhattacharya. It's a great pleasure. It's a great honor, again, as always, to be part of these Braver Angels events, and most of all, the honor that having the Tucson Alliance reach out to me, and then the honor that my friend Dr. J. Bhattacharya has afforded us some of his time tonight to join us. So I'll just first off start off and say, again, thank you, Jay, Dr. Bhattacharya, for joining me. Such a great pleasure. So Dr. J. Bhattacharya, for those who are not familiar, is a professor at Stanford University School of Medicine in the Department of Health Policy, formerly in the Department of Medicine, and a fellow at Hillsdale College's Academy for Science and Freedom. He directs the Center for Economics and Demography of Health and Aging at Stanford University. Dr. Bhattacharya's research currently focuses on the epidemiology of COVID-19, including the lethality of COVID-19 infection and the effects of lockdown policies. He is the co-author of the Great Barrington Declaration, which I'm sure will be discussed here a little bit this evening, which outlines a return to traditional public health principles for managing pandemics. This approach features focused protection for shielding vulnerable populations while eschewing harmful lockdowns that cause enormous collateral public health harms. Before COVID-19, Dr. Bhattacharya studied the health and well-being of vulnerable populations with an emphasis on the role of government programs, biomedical innovation, and health policy. His work on science policies features the development of a new algorithm to measure the novelty of published papers within biomedical science. Over his career, Dr. Bhattacharya has published over 150 articles in top peer-reviewed scientific journals in medicine, economics, health policy, epidemiology, statistics law, and public health, infectious disease, epidemiology, and pediatrics, among other fields. That's a lot. Dr. Bhattacharya is the author of a top-selling textbook, Health Economics, which is used to teach undergraduate and graduate students worldwide. For decades, he has served a grant reviewer for the National Institutes of Health, and is a contributing editor for scientific journals, including the Journal for Human Capital, the Journal of Human Capital. He holds an MD and a PhD in economics, both earned at Stanford University. So, with that, the man is incredible in both his professional and personal life. A dear friend of mine, Dr. J. Bhattacharya. I would ask that you take about 30 minutes to talk about your experiences in the early days of the pandemic, what you saw this thing as in the early days, as so many people didn't know what to expect, didn't know what was going to happen. And, you know, with your expertise, with all the things that you've done over the course of your career, you saw this thing a little bit differently than many in the public health establishment did, and you kind of wanted, for lack of a better way to say it, wanted to see things go a bit of a different way. You and your colleagues, Dr. Martin Kulldorff, Dr. Sunetra Gupta, many others among them, or among your peers, did not necessarily see this the way, or see this as something that should be handled the way that the public health establishment did, leading to a serious degradation in the trust in our public health system, which you and I have obviously talked about on the Derate the Hate podcast. And please just kind of get into that for us, and we'll go for about 30 minutes, and then we'll get some questions from those that are watching this evening.
Thank you so much for that kind introduction. It's so good to see you. We've had lots of chances to interact over the course of the last year or so, and it's just been wonderful. Learned a lot. So let me just go back in time to early 2020, when the pandemic first hit. When I saw the first reports out of China, I had a couple of ideas in my head. Based on my experience with writing in infectious disease epidemiology over the past 2 decades. First, the first idea I had was that it seemed likely the disease was much more widespread than we'd realized, even in the early days. The disease very clearly, from the reports out of China, spread by aerosols, and it was clear that it was very easily spread between humans. It was the only way to explain the huge outbreak in Wuhan, and then almost immediately reports out of places like Iran, Italy, and of course, then very soon after that, the United States, Sweden, the UK. There's no way that this disease was something like SARS-1, which spread very inefficiently between humans. The second thing I realized is, based on that observation, was that if that's true, then the early reports of the mortality rate, which was something like the World Health Organization was saying something like 3.4%, had to have been wrong. They were measuring the number of people that showed up with a severe disease in a hospital. 3.4% of them died, but they didn't know how widespread the disease actually was. And so in the very earliest days of the pandemic, sometimes things like March of 2020, I wrote an op-ed in the Wall Street Journal calling for a study, basically a study of the antibody levels in the population at large. The idea of the study was, if you have an antibody to the virus, that's evidence that you've had the virus. And that would give us a much better measure of how widespread the virus already was in the population, and that would allow us then to have a much better measure of how deadly the disease actually was. In my mind, there was no chance that it could possibly be 3.4%, and that, in fact, is what the experience that I'd seen with prior pandemics. In 2009, the World Health Organization issued a very, very dire report for the swine flu. Again, something like in the order of 4% mortality risk, but it turned out to be, after the antibody studies were done, that it was actually something like 1 in 10,000, not 1 in not 3 or 4 in 100, right? So it's a pretty standard idea to run studies like this, these antibody studies. The second thought I had is that I do health policy for a living, and I've been studying for a long time how the living circumstances of the poor and how that impacts health. And as soon as I heard about the lockdowns, my first instincts were that this was going to be a tremendously damaging response for the poor of the world. It was going to harm children. It was going to harm poor people living in poor countries, poor people living in rich countries, and it was going to harm the working class. I knew that with 100% certainty. I'll get in some detail about what that actually ended up, how it ended up playing out. But I knew that when you disrupt life the way that the lockdowns actually disrupted life, you disrupt supply systems. It's not really the richest people, not really the most well-off people that are most harmed. It's really the poorest people. In my mind, the idea that I had in my mind at the earliest time of the pandemic was that this lockdown policy was an example of trickle-down epidemiology. That we were essentially saying that asking the poor, the working class to suffer and take the brunt of the pandemic while people in the laptop class could benefit from it. That was the essential driving force, the ideology of the pandemic response that the governments around the world, including the United States government, picked. So those were the two ideas I had early in the pandemic. And I very quickly, in early April of 2020, ran a study of the antibody levels in the population in Santa Clara County, California, where I live, and then another study, a second study, a week after that, in the middle of April in Los Angeles County. And what we found was that for every person that had been identified as having been infected in April of 2020, again, very early stage of the pandemic, after several weeks of lockdown, it turned out that there were 50 people walking around Santa Clara County, walking around LA County that had antibodies that no one knew had the disease before. 50 times the number of people than public health knew. So it implied something like 50,000 cases of COVID by early April 2020 in Santa Clara County, rather than the 1,000 that the public health authorities were currently saying. That meant the death rate from the disease was 2 out of 1,000, not 3 out of 100. Much worse than the H1N1 flu. Remember, that was 1 in 10,000. This was 2 out of 1,000, and especially much worse for older people. Older people had a 3 or 4 or 5% mortality risk. For young people, especially for children, the study showed that the risk of dying was minuscule. The study then was confirmed by the LA County study, which we ran the week after, and in the months that followed, 100 or more independent research teams basically replicated our study. In an analysis published of this literature by the World Health Organization in December of 2020, our study had basically was smack dab in the middle of all these hundreds of other studies that had found something very similar, which is that the death rate from the disease was much lower, an order of magnitude lower than what the World Health Organization had said. It wasn't 3.4%, it was 0.2%. That it was much higher risk for older people than the flu, but a lower risk of death than for children. So that was the first set of things I did. As the summer wore on, what I saw was report after report essentially documenting my worry about the effects of the lockdown policies on the poor coming to life, coming to truth. Right. So for instance, schooling and learning. We closed schools down in March of 2020. And in many places, for instance, in California, where I live, we didn't open schools for in-person instruction for a full year and a half. And it wasn't well-off people and well-off kids that suffered the most, although they did suffer also. It's poor families of poor kids that suffered the most, because they couldn't replace the missed schooling with tutoring, with pods. You saw in richer communities, you saw essentially like even teachers who were not didn't have to go to school, hired by well-off families, whereas you had poor kids essentially falling further and further behind. The thought that kept going through my head was, how do you teach a 6-year-old to read online? And the answer is you don't. The documentation about the learning loss since then has been devastating. Kids have lost something on the order of, something between 3 to 9 months of schooling on area after area. What we've seen is a decreased achievement in learning. And I should tell you, there's a social science literature that precedes the pandemic that documents that if you have even short periods of interruption in children's schooling, it has long-run consequences on the health and well-being of children for their entire life. Children, for the estimates by the editor of JAMA Pediatrics in the middle of 2020 suggested that by closing schools in the spring of 2020, we had cost our children in the United States something on the order of 5.5 million life years, because they will lead shorter, poorer, less healthy lives as a consequence of the learning loss that they've suffered. Poverty causes deaths. So that's one. The literature in the psychological literature was absolutely devastating. I'll just pick. There's a lot there, but I'll just pick one that came out in June of 2020. The U.S. CDC put out an estimate that 1 in 4 young adults had seriously considered suicide in the previous month during the lockdowns. It's 1 in 4 young adults, a sharp increase in the normal rate of that suicidality. And in fact, what's happened in the years since is we've seen a huge increase in suicidality, in drug overdoses, in all kinds of psychological harm, depression, anxiety, alcoholism. These were all entirely predictable. In fact, they were predicted and they've come about. People were told by public health that it was dangerous to go to hospitals, in effect, that it was so dangerous, that the disease was so dangerous that it was better to stay home. And people listened. And so as a result, a huge number of people decided that they wouldn't get their cancer screening. And we've seen what's happened since is, and again, entirely predictable, a huge increase in the number of people who have had late-stage cancer that should have been diagnosed earlier, that are going to die as a result, that should have survived. People stayed home with heart attacks, thinking that it was better to stay home and die of a heart attack than to go to the hospital and get COVID. We had a tremendous increase in preventable deaths as a consequence of the fear-mongering that public health authorities put out about COVID, rather than looking at this literature sort of more reasonably. The international evidence was even worse and completely heartbreaking. The World Bank put out an estimate again I think in April and May 2020 that there would be 100 million people that would be put on the brink of dire poverty. That is $2 or less of income. When we talk about supply chain disruptions, well, over the last 40 years or so, the increased globalization of the world economy, it's lifted 1 billion people out of poverty. But the way it did that was that all these poor countries, so many of them reorganized their labor markets so that they were dependent on trade with the West. When that ended with the lockdowns, what that meant was a very large number of families had no means to support themselves, that their children starved. There was an estimate put out by the UN World Food Program that 130 million additional people would face dire food insecurity. I don't think it ended up quite that bad, but on the order of tens of millions of people additional faced starvation as a consequence of the lockdown policies we followed. The schooling loss, which was bad in the US, was even worse in poor countries. Just to take one data point, in Uganda, for instance, 15 million children were locked out of schools for 2 years, meaning no school. Like they didn't really have Zoom school at all. And 4.5 million of those kids, after 2 years off of school, never came back. It's a generational inequality that we've caused by our short-sighted lockdown policies. And those 4.5 million kids, a UN report suggests that many of them, the reason they didn't come back is because their parents were forced to make a choice between their kids starving or sending their kids to child labor, or even worse, sexual slavery. What we had was a catastrophic destruction of the lives of the poor as a consequence, and again, entirely predictably from the lockdown policies we followed. Okay, so that's summer of 2020. In October of 2020, I wrote a document with two of my colleagues, Martin Kulldorff, then of Harvard University, and Sunetra Gupta of Oxford University. Martin and Sunetra are among the most accomplished epidemiologists and biostatisticians in the world. Martin, for instance, designed the vaccine safety surveillance system that the CDC and the FDA currently use. Sunetra is the professor of theoretical epidemiology at Stanford, or at Oxford, and she is working on a universal flu vaccine. She's an incredibly accomplished scientist. We met in Great Barrington, Massachusetts, and we realized that we'd had essentially arrived at the same place, that the lockdowns had failed to protect older people from the disease, that there were, in fact, even by October 2020, it was clear that 80% of the deaths were in older people. So if the idea was that the lockdowns would stop the spread of the disease and protect older people, they had already failed to do so. That the disease was coming back. There was no chance that the disease had gone away. In fact, it's impossible for the disease to go away. We'll have COVID with us for the rest of time. And that the lockdowns had done tremendous damage. So we wrote the Great Barrington Declaration in October 2020. The idea of the Great Barrington Declaration rests on the scientific foundation I've already told you. So one is that there was this huge age gradient in the risk of dying from COVID. Older people face much higher risk than young people. In fact, children face vanishingly small risk of dying from infection with COVID, something on the order of 1 in 400,000 to 1 in a million, depending on the age. Every 7 years of age, the risk of dying doubles. So, for instance, for a 52-year-old, it would be 2 out of 1,000. 59-year-olds would be 4 out of 1,000. 67-year-olds, 66-year-olds would be 8 out of 1,000, and so on. And if you go back down the other direction, 45-year-olds would be 1 out of 1,000. 38-year-olds would be, 5 out of 10,000. Smaller and smaller and smaller as you get younger and younger and younger. Much vanishingly small risk. The risk of long-term outcomes from COVID seemed to me, from the literature, very clearly overblown, in the sense that whenever there were studies in children comparing children who were infected with COVID with a control group of uninfected children, the long-term outcomes were similar for the two groups, infected or uninfected. It's not that long COVID doesn't happen. It just happens at much lower rates than some of the fear-mongering. And in any case, there wasn't a way to prevent it from happening, in the sense of we didn't have a technology to stop it. The lockdowns did not actually stop anyone other than maybe the richest people in the world from getting COVID. Okay, so you had the age stratification. You had tremendous lockdown harms. So the Great Barrington Declaration called for was focused protection of vulnerable older people. What that meant was, what we wanted to have is a lot of young people, what we wanted to have was that that public health engage more creatively with ideas about how to protect vulnerable older people. The public health operate under the idea that lockdowns would by themselves protect old people by reducing disease spread in the population, but that had failed. The antibody evidence from all over the world suggested that it already had failed to do so. And if you look at places that locked down versus places that didn't lock down, for longer term outcomes, there was very little evidence that the lockdowns had any effect whatsoever on disease spread. At best, what they did is they delayed by a little while when the disease came. Again, a tremendous harm to the poor, to the vulnerable, to children, the working class people. So we call for a lifting of lockdowns, especially making the lives of children as normal as possible. That was the Great Barrington Declaration. Focused protection of vulnerable older people and lifting of lockdowns. And in the document itself, it's a one-page document. We gave a number of ideas for how best to do focused protection, but that would depend, of course, on the living circumstances of the elderly, which differ from place to place. Focused protection means something very, very different in Los Angeles, California, than it would mean in Mumbai, or it would mean in a rural area in Sweden, for instance. What was needed was policies that were designed for the local populations, which required public health officials to think carefully and creatively about how to accomplish that. So things we called for included expanded sick time for people so that they didn't have to come to work sick, a sabbatical time for older workers, especially when the disease was spreading, changes in how nursing home staffing works, so that nursing home staff didn't increase the risk of bringing the COVID from the community into the nursing homes. A whole host of measures that we suggested. We were hoping to have that the public health authorities would join us in thinking how best to protect people from vulnerable older people from COVID. Just to give you a sense of how badly that went in terms of relying on lockdowns to protect older people from COVID. If you ask, why did, for instance, Governor Cuomo send COVID-infected patients back to nursing homes in the early days of the pandemic? I don't think it was an evil intent. I think it was an intellectual mistake. The mistake was thinking that what needed to be protected was hospital systems rather than vulnerable older people. If the priority had been protection of vulnerable older people, it would have been unthinkable to send COVID-infected patients to nursing homes, because that's where the most vulnerable people were. So what we were calling for is a reshuffling of the intellectual infrastructure so that the protection of vulnerable people was the most important goal of public policy, of public health policy, rather than a whole host of other goals that seem to have taken hold. An abandonment of trickle-down epidemiology and a lifting of lockdowns, which were harming the lives of so many. So when we wrote the declaration, we put it on a website, and it went viral. Tens of thousands of epidemiologists, doctors, and scientists signed it almost immediately after we released it. And almost 1 million regular people signed the declaration very shortly after we released it. One of the major reasons why we wrote the declaration was to let the world know that there was not a consensus in favor of the lockdown strategies that the United States and the world had followed. In fact, there was tremendous levels of unease in the scientific community about lockdowns, even though it was if you read the newspapers or you listened to the top government scientists, you would think that everyone agreed that lockdowns were the right way. That I knew that was not true. Many of my fellow scientists that I spoke with thought that the lockdowns were a terrible idea. And the Great Barrington Declaration, especially the reaction of the scientific community with tens of thousands of scientists signing it and doctors signing it, made it very clear that was correct, that there was in fact a huge debate going on that the public did not know about regarding the wisdom of lockdowns. Now, the problem was that the government scientific bureaucracy wanted to maintain an illusion that lockdowns were the only way. We wrote this in October 2020, October 4, 2020. 4 days after we wrote the Great Barrington Declaration, Francis Collins, the head of the National Institute of Health, wrote an email to Tony Fauci, the head of the National Institute of Allergy and Infectious Disease, calling me, Martin Kulldorff, and Sunetra Gupta, the three authors of the Great Barrington Declaration. He wrote and called us fringe epidemiologists, an ad hominem attack. This despite the fact that we were three of us professors at some of the top universities in the world. With decades of experience in infectious disease epidemiology and public health. He called for a devastating takedown of the premises of the declaration, and Tony Fauci responded to that email with a hit piece in Wired magazine, accusing me, Martin, and Sunetra of having political motives, accusing us of wanting to let the virus rip, when in fact the most important plank of the Great Barrington Declaration was a call for better focused protection of the vulnerable older people. We were not calling to let the virus rip. That was a slur. Rather than engage with us intellectually to try to think about how better to protect vulnerable older people, the reaction of the scientific scientific bureaucracies of the world was to destroy us. The censorship of the Great Barrington Declaration in online settings began almost immediately. There was a hit piece. If you look on Wikipedia, you can probably still see evidence of it, about, again, accusing us of wanting to let the virus rip. Google deboosted the Great Barrington Declaration. Facebook censored us. Mentions of the Great Barrington Declaration on Twitter before Elon took over was often met with deboosting or actually just getting kicked off the platform. there were scientists who signed the Great Barrier Reef Declaration who lost their jobs in universities and in independent labs as a consequence of signing it. Doctors who signed it faced pressure from their specialty societies. In Canada, there's still ongoing action against doctors who tweeted about the Great Barrington Declaration. The pressure from scientific bureaucracies to censor, smear, and destroy the reputations of anyone who came anywhere close to the Great Barrington Declaration was tremendous. And I'm sorry to report that this was was spearheaded by the top scientific bureaucrats in the United States, in the UK, and elsewhere. I should just say why this is such a violation of scientific norms. In fact, it was an abuse of power by these scientific bureaucracies. An organization like the National Institute of Health is an incredibly important institution for funding science in the United States and in the world. But it's not just that they fund science. What they do is they pick and choose who in the scientific community is going to get to run their experiments and who in the scientific community is going to gain status within the scientific community. For instance, I have tenure at Stanford University. I don't get tenure unless I'm successful as a NIH researcher. I have a long career, 2 decades of winning NIH grants. It's partly why I managed to get tenure at Stanford. When Francis Collins wrote that email calling us fringe epidemiologists, he was sending a signal to other scientists to stay silent. And that's exactly what many scientists did in a consequence of that signal. What should have happened was an honest debate about the wisdom of lockdowns and about the wisdom of focused protection, which is what we were proposing. Instead, what happened was silencing, censoring, and smearing of scientists. I'm almost out of time, so I'll just finish with a couple of remarks about the results now 3.5 years on. And I could go on and on about the harms of lockdowns. Almost all of the predictions came to pass regarding the harms to the poor, the vulnerable, to children, the working class. Heartbreaking stories are going to come out over the next decade where we hear about these harms of lockdowns and the long-term consequences of them, which are still ongoing. But I'll just leave with one statistic about all-cause excess deaths. How well did the lockdown strategies that we actually followed, how well did they protect human life? And for that, what you need to do is you need to look at places that didn't lock down or had fewer restrictions compared to places that did. And for that, I think the best control group in the world is Sweden. Sweden, while it had some failures very early in the pandemic to protect older people, especially in nursing homes, it largely followed a policy of focused protection. It structured its society so that it provided opportunities for older people to be shielded through sick leave and whole host of other policies, while letting the rest of the population live normally. And as a result, the all-cause excess deaths is how many deaths there are relative to what you would have expected given the death rates before COVID and given the age structure of the population. The all-cause excess deaths in Sweden are either the lowest or the second lowest in all of Europe. It's lower than Norway, lower than Denmark, lower than Germany. I'm sorry, lower than Finland. I think Denmark is either right there with them or just behind them. But much lower than the United States, for instance. In the United States, you can compare, for instance, Florida versus California. All-cause age-adjusted deaths, excess deaths, are higher in California than in Florida since the start of the pandemic. California did a worse job of protecting human life than Florida did since the start of the pandemic. And Florida didn't close schools in the fall of 2020. My kids were out of school for a full 1.5 years. What purpose did that serve? It didn't end up protecting grandma and grandpa in California. So the lockdowns then were catastrophic policy that didn't end up having the effect of protecting human life and also causing all the excess harms. Had we followed the Great Barrington Declaration, which, by the way, was the standard for how we managed every respiratory virus pandemic for the century before, protection of vulnerable people, not panicking the rest of the population. Had we followed that, we would have had better outcomes for COVID, and of course, we would have avoided the lockdown harms. As things stand now, the establishment figures that push the lockdown policy are effectively working to enshrine it as the standard way we manage pandemics into the future. In the UK, there's currently a COVID inquiry going on, where the established figures are essentially saying that the lockdowns were a great idea, and the only problem was that they weren't implemented hard enough, that we weren't able to have the kind of totalitarian control that China had. But even China failed with the lockdowns. The Chinese lockdowns didn't protect the Chinese population. The estimates from China, not the official estimates, but the estimates based on a whole variety of sources, suggest that millions of people died in China too from COVID. And of course, the draconian lockdowns in China had tremendous negative effects. We should have followed the Swedish example. We should have allowed there to be scientific and policy debate. And I think had we done so, the Great Barrington Declaration would have won the day, because it was the standard pandemic plan that we'd followed for a century before successfully. And unless in this country and elsewhere we take an honest accounting of the failures of the lockdown policies and enshrine in our plans the old ideas which are embodied in the Great Barrington Declaration, all of this will happen again.
Very good. And looks like you had with 2 minutes to spare. That's a lot to pack into 28 minutes. So I hope everybody was taking notes. That's yeah, there's so much to unpack there, and so many questions from our great audience tonight. And I know this first question may be a lot, Jay, of what you've touched on already, but I do want to give it its due and start with this question. Since we do have just 1 quick minute of your time left before we get into the question, I want to take just a quick point of privilege as the MC tonight, and say with the Great Barrington Declaration, and I don't know if this was one of the questions, but I know it's something that's come up before with the Great Barrington Declaration and how it was being proposed. Was it proposed just online? Is it something that you guys proposed online and we're hoping that it would grab legs that way, or was there any kind of back channels with with Scott Atlas and Alex Azar and those folks? Can you just briefly take a quick minute to talk about that, and then we'll get into the questions from the audience?
Sure. So yeah, so I mean, mainly we put it online. It took off by itself online. Beyond my furthest expectations. But we also did get to visit with Secretary Alex Azar to talk about the Great Barrington Declaration about a week, I think, a few days after the Great Barrington Declaration. In that meeting with him in October 2020, we emphasized exactly what we said in the Great Barrington Declaration, that it was very important to do better focused protection of vulnerable older people, and that it was very important to open schools. Opening schools was probably the most important plank in what we were suggesting. And Azar was really interesting. Seemed open to both ideas, but seemed also like he had been cut out of the policy making. In fact, expressed that exact frustration to me regarding his ability to move the Trump administration policy. It was interesting to watch. I mean, I'd never expected to go talk with top government officials. With the Great Barrington Declaration, we had that opportunity, but I think unfortunately we didn't really move people to act.
Okay. Well, thanks for that. So we'll get into the questions then. So our first question for Dr. Bhattacharya tonight is, tell us about the ways, and like I said, this one I think you got a lot into, but if there's anything in this question that you feel you can elaborate on, please do so. So tell us about the ways in which you were censored, including relating to your position in the Great Barrington Declaration, why you think you were censored and by whom, and then what do you think is the impact of censorship on informed consent and different health outcomes.
Yeah, so the censorship, there's a lot I could go into, but I'll just tell you briefly about a case that I'm involved with as a plaintiff. It's the Missouri versus Biden case. It's a case brought by the Missouri and Louisiana Attorney General's office against the Biden administration. That case was heard by a federal district judge who allowed us to do discovery. And in that discovery, we read the emails from the Biden White House to Twitter, to Facebook, and a whole bunch of other places. We got to depose Tony Fauci. We got to depose Biden administration officials, including in the White House itself, the Surgeon General's office, the CDC. What it uncovered was a vast censorship enterprise. And it works in two ways. One is that the federal government farms out the job of finding who and what to censor on social media, what ideas are trending that are contrary to what the government wants out there on COVID policy, on vaccination, and much else, and then what like who specifically are saying those ideas effectively. Then the White House then goes to the various social media companies and says, you need to implement this censorship regime, and if you don't, then we will regulate you out of existence. In fact, they say they have in effect threatened the viability of these social media companies. The federal judge that heard the case and wrote the decision called it a Orwellian ministry of truth, a censorship industrial complex. Then it was appealed by the Biden administration to the Fifth Circuit Court of Appeals, who also agreed that it was a censorship industrial complex and put in an injunction, but essentially prohibiting the Biden administration from doing these censorship activity, going to the social media companies and saying, you need to censor these people and these ideas. And right now, it's currently sitting at the Supreme Court. We're hoping to get a ruling, and the Supreme Court has actually accepted the case, which is a big step. It's probably among the most important First Amendment cases in the history of the nation. Essentially, what has happened is that the government took it on itself to say, we're going to suppress legal speech because we think it hurts public health. And there's a second part to the question. Let me just answer real briefly. I think that while it's true there is misinformation online and that people act on that misinformation, the best counter to that misinformation online isn't censorship, because what that does is it breeds distrust. The best counter to misinformation online is honest communication from a trustworthy public health agency. If the public health agency is acting in good faith and honestly in trustworthy ways, people will trust it. And it's not everyone will trust it. Of course, everyone, that's not possible, but more people will trust it. Instead, what we have now is essentially a discussion going on sub rosa with this pressure cooker lid put on top of it. And it's bred a tremendous amount of distrust in our institutions. It seems like it's been terrible to watch. And I will say the other thing about the effect on health, had we had an honest conversation, not suppressed, without the smearing, without the ad hominem attacks, fringe epidemiology, we would have, I think we would have had a very different policy, Wilk. We would have had a policy that would have avoided the lockdowns, that would have avoided the harms to the children, the closing of schools, that we would have given voice to the poor of the world who were suffering through starvation and impoverishment. It would have allowed there to be a counter, and I think a very effective counter, and it would have forced public health agencies to think much more creatively how to better protect vulnerable older people. I think a lot of people are dead and impoverished as a consequence of this censorship that the government decided on its own that it was going to impose on this country.
Yeah, I think one of the biggest things that I took away from you and I's conversation on the Derate the Hate podcast was how that censorship and how the resulting distrust from that censorship just helped to exacerbate the bad narratives that were out there. It wasn't a situation where people really felt that there was an honest conversation happening, but it which allowed for so many of these other ugly narratives. Once the trust was eroded, people started to believe. It wasn't that they didn't believe anything; they just started believing everything. So,
Absolutely.
all right. Next question: what are the best sources and ways, Dr. Bhattacharya, to count the deaths from, not with, but from COVID, and the deaths not with, but from mRNA shots? Considering bias in reporting, media attention, financial incentives, and more, what is your best guess of the current death counts from and the continued side effects from both COVID and then the mRNA vaccine shots?
That's a really complicated question because it's statistically it's very difficult to distinguish with versus from. The way that we counted deaths from COVID, we incentivized people on their death certificates to have a COVID diagnosis, even if it wasn't the primary cause of death, because that let you have $10,000 of FEMA money for funeral benefit. Like if you die of cancer in this country, you get nothing. If you die of COVID with COVID on the death certificate, you get $10,000 for funeral benefit. And the other thing is that the lethality of COVID has changed pretty substantially over time. It was most lethal when it first arrived because we had an immune naive population. And now people getting COVID is much milder in some sense because they've probably already seen COVID before, or they've had the vaccine or something. It's less severe. And so in the early days of COVID, I'd say based on estimates that I've seen, something like 1 in 4 people who had COVID on their death certificate probably died of something else, and COVID was just incidental. And now I think that fraction is much higher, that there's many more people who are COVID is just incidental, it just happens to be on the death certificate. I have not seen an excellent report disentangling this. In part, I think it's because it's just a difficult thing to do, because you have to go back over the death certificates to have a random sample, look, tie it back to the health records of the patients that died, and then try to do your best guess for, was this incidental or not. Essentially, it's like a detective problem, and doing it at scale is quite hard. On the vaccines and the effect of vaccines on deaths, and I'd say maybe I'll be unpopular, some of the folks that follow me on this. I think the vaccines in 2021 were quite important for protecting the health of older people. In fact, I argue that older people be prioritized for the vaccines worldwide, not just in the United States, because the evidence from both from like early epidemiological data suggested that the places that had higher rates of older people being vaccinated had lower COVID deaths.
Nice.
I think the vaccines, on the other hand, for young people have had very little to no effect on deaths. It might even be negative. It might actually have caused more deaths than it saved, because it does, especially in young men, cause myocarditis. Myocarditis is inflammation of the heart at some rates, which can be deadly. I don't think it's an enormous effect on deaths in that group, but I do think that it's one of these things where, like, you wouldn't give, unless you knew for certain that a drug or a product has a expected net benefit for a group, you wouldn't recommend it to that group. And we recommended vaccines, these COVID vaccines, to young people with very little evidence to suggest that it would benefit them, and without knowing for certain what the side effects were. It turns out for young men, the side effects can be quite severe. And people will argue over exactly the rates of it. The right thing to do would have been to use the vaccine for focused protection of vulnerable older people, and then allow people, if they would like, to have access with informed consent about all kinds of things that would, for instance, to tell people, we don't know what the side effects of this vaccine are going to be. We're still finding out. The vaccines trials only allow us a small window into that, but we're going to find out new things. I think if people had been told that, they would have acted very differently. Certainly, we wouldn't have had vaccine mandates that led to further distrust. I just saw a report that for the first time in many years, the uptake of the normal vaccines, the MMR vaccine, the childhood vaccines has collapsed in the U.S. It's really shrunk in the U.S. And that is the fruit of the distrust caused by the mandates of this vaccine, and essentially the including of this vaccine in the childhood vaccination schedule without any evidence of net benefit for children from this vaccine. If the vaccine had been focused on older people, I think we'd have looked back on the vaccine with tremendous happiness, thinking it had saved the lives of a lot of people. But now it's not clear that we're going to look at it that way. Instead, it's this mixed legacy of saving the lives, I think, of some people, especially in 2021, before everyone had COVID. But also this distrust that have come from a lot of people losing their jobs because of the vaccine mandates, a lot of people getting hurt by the vaccine side effects.
Mm-hmm. No, I think that's a fantastic way to put it, is a mixed legacy. And while it's a fantastic way to put it, it's a sad thing to say, because it's something that's come up in several of my conversations on how the vaccine mandates and people's distrust and not trusting of this particular vaccine has led to the distrust in so many other vaccines, which we know, even me, just some blue collar guy from the Midwest, I understand that vaccines are a very, very important part of our human legacy, right? And now that there are people out there that are not going to get their kids vaccinated because of this particular vaccine, is a nightmare scenario for so many people. So that answered actually the next question, Jay, was do you believe the original COVID-19 vaccines were a good, a net good? So yeah, that answered that. So thank you for that. Now, what impact do you believe censorship, and I think this is probably something that you've already gone over in this conversation, but what impact do you believe that censorship had on COVID policy overall? So take a quick minute to talk about that.
Just very quickly, I don't think the lockdowns could have survived without that censorship regime. I think there would have been tremendous outcry from huge numbers of people. Remember, there were actually, I remember, like anti-lockdown protests, and essentially there was like a concerted effort to like smear people that spoke up against lockdowns. Mm-hmm. Even people that were prominent that had sort of scientific background. You didn't need a scientific background, Wilk, to say that the lockdowns were tremendously harmful. Everybody felt that, and yet people couldn't say it. The Great Barrington Declaration, if it had any success at all, was to let people give permission to people to say, you can say that the lockdowns are not a good idea. Mm-hmm. You could say it because there's 3 scientists that are saying it, right? That the censorship, the destruction of the reputation of me, Martin, and Sunetra was necessary in order to keep the idea, this illusion of consensus, in favor of the lockdowns. If that censorship regime, that smearing regime, hadn't been in place, I don't think that the lockdowns could have survived the light of day. There would have been tremendous scientific work and scientists opposing them, and they would have won. Instead, we lost that argument in 2020. The lockdowns came in place. We got the policies that the scientific bureaucracies wanted.
Right. No, I think you're exactly right. So, what, if any, studies are out there looking at the effects of policies enacted during the pandemic? So, is there any increase in comorbidities or mental health issues? And yes, I believe that, again, there's another one. You nailed it out of the park with your conversation here, because you've covered a lot of this already. Take another quick minute. What do you think? Increase in comorbidities, mental health issues, things of the like.
It's heartbreaking to watch, Wilk. It's been heartbreaking to read this literature. I mean, just a tremendous number of studies are now coming out. And I think I mentioned some of them about the harms to children, the educational harms to children. Some of the worst to read for me, is just the most heartbreaking to read, are stories of child abuse, right? You close schools, and what happens is you lock in children with abusers sometimes, and it's schools where that abuse is picked up. Now, in the US, that was bad, but in poor countries, it was even worse. Huge amounts of human suffering as a consequence of essentially undermining the systems we normally have to pick up this suffering and to address it. Domestic abuse, something I didn't mention earlier, went up during the lockdowns. The medical overhang in places like the UK, which still has tremendous high all-cause excess deaths, huge backlogs of patients that have not been seen as a consequence of the lockdowns. In the US, it's a little bit better for those backlogs, But you're still seeing this stage shift in cancer, more cancers diagnosed at later stages than previously. You're seeing the depression at all-time highs, anxiety at all-time highs, overdoses from drug abuse, from fentanyl. Some of it's very complicated. It's not just the lockdowns that caused this, but the lockdowns exacerbated the conditions that allowed those things to be worse. And it's been heartbreaking to read that literature, but I think we have to keep our eyes on it. We have to force ourselves to see what we've done so we understand that we don't ever want to do it again.
Yeah. So I know we're getting real close to the end of our time here. There's two more questions here I'd like to get to really quick, Dr. Bhattacharya, and that's so if you could answer them as fairly quickly, and then we'll get wrapped up for the evening. Apart from the mandates, what advice would you give to your patients about when and if they should mask?
Okay, so first of all, I should just say I'm a research scientist and a research doctor, not a I don't see patients myself. My wife sees patients, as she tells me all about the time. I think that the evidence on masking was very poor. There's a good reason why people at the start of the pandemic did not recommend masking, including people like Tony Fauci. There were a dozen randomized studies from before the pandemic on masking in the flu, which spreads in a very similar way to COVID, that failed to show any benefit. I do not understand why, from a purely scientific point of view, masking became this thing that people recommended. And what it actually became was a talisman. I think it's quite possible that more people died as a consequence of the recommendation to mask, because a lot of vulnerable older people were told, if you mask, you're safe. And so they wore cloth masks, and early in the pandemic walked out, got exposed to things, and the mask didn't protect them. I think if I had to pick estimate the number of people saved by masks, I think it's likely negative.
Okay.
If you wear an N95 mask and you take it off every 2 hours and you've shaved, you can't wear that beard, but Wilk, I'm sorry.
Oh no.
You might be able to, you might get some benefit from it for a short period of time, but just to ask everyone to do it at scale for years was a tremendous mistake.
I believe so. I agree. Do you think that trust would be rebuilt by a Braver Angels guided meeting on the various sides of the COVID policy to find common ground in acknowledging errors made by policy, errors made in policy for our future?
Well, I love your organization. I love Braver Angels. It's incredible. I didn't know about it before you contacted me. And what I've learned of it is I think that's exactly the way we heal. We have to talk to one another. Censorship is the death of talking to one another. It's like saying, I don't want to even hear you. Not like I don't want to hear you. I don't want anyone else to hear you either. It's the opposite of what you guys stand for. It's hard conversations between people who disagree on things is the way we solve problems. We don't do it by ad hominem attacks. We do it by an honest, grappling with the data and the arguments. And I think that's the only way forward. I'm really glad for your organization to be working toward that.
Thank you so much, Dr. Jay Bhattacharya. You've been an incredible guest here tonight. And again, as always, I'm so honored to call you a friend, and I hope we get to do it again real soon. One last word, and then we'll turn this over to back over to Martin from the Tucson, Arizona Alliance.
Wilk, the honor's mine, and I'm so honored to call you a friend as well. Thank you for this, and to the folks that are listening, thank you for the opportunity to let me have my say. Really grateful to you.
All right. Thank you. Martin?
Yeah, let me change the spotlight here. All right. Fantastic. Thank you so much. That was hugely informative, and I hope you all enjoyed this as much as I did.